Hello, everyone. Welcome to the BackTable podcast, your source for all things interventional and endovascular. I'm your host, Dr. Baheti, coming to you from Tacoma, Washington. I have two guests today, Jill Sommerset, Director of Ultrasound at Advanced Vascular Center in Portland, Oregon, and Hope Clinical Innovation Center in Houston, Texas. She's also the chair of the SVU Annual Conference and serves on the board of directors for SVU. Jill, thank you so much for being here.
Thank you, Dr. Baheti, and thank you, BackTable, for the invitation to be here today.
My second guest is Dr. Fadi Saab, interventional cardiologist and director of Advanced Cardiac and Vascular Amputation Prevention Centers and associate professor at Michigan State University. Dr. Saab, thank you for being here.
Thank you for the kind invitation. Happy to be here.
Our topic today is EVUS to IVUS, a continuous spectrum. So let's start with some basic questions for the uninitiated. Dr. Saab, I'm going to let you take this one. What is IVUS and what is EVUS?
Yeah, sure. So when we start thinking about ultrasound technology, it is the ability to visualize three-dimensional structures in a way that's different than fluoroscopy and radiation. And to that concept, we currently are lucky to have what I think is two major categories: extravascular ultrasound, which is EVUS, and intravascular ultrasound, which is IVUS. And the way I think of EVUS is basically us shining a light and visualizing things from the outside toward the inside. So in very simple terms, from outside the body to inside the body. Especially when it comes to vascular ultrasound, visualizing vasculature from the skin deeper into the tissue. And the way I tend to think of intravascular ultrasound is visualizing the structures from the inside to the outside. So in the case of veins or arteries, visualizing these arterial and venous structures from the inside of these structures to the outside of a body, in a nutshell.
Okay. Anything to add to that, Jill?
Yeah, I think the beauty of ultrasound too, extravascular ultrasound, is we get hemodynamics. So we get a live feedback of the hemodynamics in the vasculature, which is really nice to have that additional information.
For sure. I had the pleasure of recently visiting Jill's center and seeing what a wizard she is with extravascular ultrasound. I don't think it's not even just like looking at the right places. It's all the dynamic gymnastic movements you make during the procedure to get the correct pictures, which that really got me. But I'd like to just dive in and talk a little bit about case selection for extravascular ultrasound. Jill, with the physicians you work with, do you use this for every case?
Not every case. And thank you, Dr. Baheti. It was really nice to have you in the lab. But before I answer your question, I just wanted to share a short story, Dr. Saab. You probably don't remember me, but back in 2014, I joined the CSI course. And I have to give you and Dr. Mustafa so much credit because you opened up the world to an ultrasound tech being in the cath lab. And that's when Lindsay worked with you. And I thought, oh my gosh, I want to do that. So I just want to say thank you for opening up the world for vascular techs to have a role and a place in the cath lab, because it is so valuable. And I love it so much. And I think to answer your question about case selection, Dr. Baheti, is that, I scan all of these arterial patients and I'm constantly in my mind thinking, are they a candidate for EVUS?
Sure.
And some of them it's no, like it's a huge rock pile in the distal SFA. And I know that ultrasound is going to be limiting. And oftentimes I'll be like, yes, this is a great EVUS case. Let's book it on a day when I'm going to be there. And you can almost tell. Dr. Constantino will bring me in anyway, just, we can try different angles. But you oftentimes know the cases that are going to be limited by EVUS, and then we have to rely obviously on our other tools, such as IVUS and fluoroscopy. Dr. Saab, do your techs do all of the duplex ultrasound, or do you have a separate group? Because I know your techs are more interventional ultrasonographers, which is really amazing. I'm just curious how it works in your facility.
Jill, you're very kind. You're very humble. It's you've done a lot to the field, and you've done a lot to your peers and to your colleagues, and quite frankly, to a lot of us endovascular specialists that work in this field. And I might venture to say, and I don't think it's an exaggeration, I use the term interventional radiologist, interventional ultrasonographer quite a bit. And I introduce a lot of our ultrasonographers as interventional ultrasonographers. And that really pours into the question you just posed, because I know, without you even telling me, you and I did not compare notes. The way you scan the patients in the ultrasound suite or the ultrasound lab, even if they're not having a procedure, as an interventional ultrasonographer, and I think you are one of those interventional ultrasonographers, the way you scan those patients is very different from and I don't mean it in a way that diminishes the role of the regular ultrasonographers. It's just your view, your thought process is quite different than ultrasonographers that are not in the interventional suite, because you've already evolved from that, okay, my role here is to provide imaging, hemodynamic assessment, and images of the structures that we need to treat. And you've already evolved into the next stage where, all right, now I need to think about the concept of revascularization and tackling the types of lesions and the types of vessels that I'm looking at under ultrasound, and provide within my capacity feedback to the physician that I'm working with and explain to them, what am I looking at? And you made a nice example. You said this is not a good case for EVUS, but what you're actually saying, this is a highly complex lesion that's going to be challenging no matter what the physician is going to do. You already provided valuable information to the physician beyond fluoroscopy. And I think that's what we're witnessing. This is, to me, what's so exciting about extravascular ultrasound with people like Jill and a lot of our ultrasonographers. They're really paving the way for what I think is a new specialty in the field that's going to translate into better success rate, better outcomes, and lower complications.
So, Dr. Saab, do you set up all your cases with EVUS, or do you rely on the input from your interventional sonographer as well?
So we made a conscious decision in our lab that we always have an interventional ultrasonographer as a member of the team. So we don't book them on and off. That number one, because the majority of our patients are critical limb ischemia patients. This is kind of the most advanced form of PAD. But number two, we feel that. And I think Jill will talk about that also some more. We feel that beyond actually extending our ability to deliver care, it's an extra level of safety for the patients. So it's not only obtaining access, I think ultrasonography or extravascular ultrasound is more sensitive in picking up complications, is more sensitive in documenting success or failure of an intervention. Is more, so when the patient leaves our lab, leaves the cath lab suite, we've already, had our check mark checked, and we're not concerned about certain types of common complications that can happen to anybody. So to answer your question, we always have an interventional ultrasonographer with us as a member of the team.
I see. Yeah. And then, Jill, you alluded to some situations where EVUS might not be helpful, like if there's a big rock hard plaque. Any other scenarios that you commonly see where that EVUS isn't going to be helpful in a case?
Yeah, I think we've learned a lot, and we know that there are challenging places like, the Hunter's Canal or the tibial perineal trunk. It can be hard on some patients, and I'm very forthcoming about where I think there's limitations of ultrasound. But by and large, EVUS is so valuable in the cath lab for access, for closure, for crossing lesions, for staying true lumen, for vessel sizing. I'm always trying to, race against IVUS because I want to be better. So I think there's just so much value. So there's not that many cases where we can't really use EVUS. We all know that rock pile in the Hunter's Canal where it's just a shadow, and we know that. But by and large, the case that you saw, Dr. Baheti, it was lovely. We came from, pedal axis and got through the origin SFA occlusion pretty nicely using EVUS. But I do think there's a lot for people to understand, especially techs, to understand what happens in the cath lab. And you have to understand wires, catheters. I know this case hopefully better than the physician performing, because I did the ultrasound. So I'm going to be I'm trying to think 2 steps ahead of her. And I'm also looking for windows when I can check something when they're doing an exchange of a wire or catheter. So it's a little bit of a dance. Would you agree, Dr. Saab? This dance between the vascular ultrasonographer and the operator.
Completely agree. Which actually I always ask our ultrasonographers, because I think it's an important thing that we physicians need to highlight the importance of your role, and we are privileged to witness the birth of this interventional ultrasonography field. And I gotta ask you, when you first started scanning in the ultrasound suite, and then you started moving to the cath lab or the endo suite, how long would you say that it took you to kind of change your mindset from, okay, I'm the ultrasonographer, to like what you just pointed out? There is even nonverbal communication because you're so advanced in what you do, and you have this understanding with you and Dr. Constantino together. She does not need to give you verbal cues. You don't need to give her verbal cues. You're already going in your mind through a list of things that you're going to check. I'm checking the catheter in the short axis view. I'm checking the catheter in the long axis view. I'm checking that the wire did not leave the vessel. I'm checking that there's no hematoma. I know you're already doing that in your head, and you're not even verbalizing Dr. Constantino because she depends on you to do that. But I'm going to ask you, how long do you think it took you to change your mindset from an ultrasonographer to an interventional ultrasonographer?
Yeah, it's such a good question. So going back to the story of 2014, and I went with a vascular surgeon, and we came back and made a commitment that we are going to make this work. And it's almost this, investment, and he was a champion for me. And it was not easy for me to step into a cath lab. Sometimes cath labs can be a little territorial, and they're like, what is ultrasound doing here? And why? What? Don't touch anything.
Dr. Saab, it's kind of like being like a third-year medical student, and you're like on your surgery rotation for the first time, and you like
rolling their eyes
right.
at you.
Yeah.
Yeah.
Yeah. So it was a little difficult. It took a good solid 4 months to gain the trust of the cath lab staff, to really watch and learn, and then actually weekly review of cases, like, tell me more about this wire, this catheter, this atherectomy device. What are you thinking? What was the outcome? What should I be doing better? So I would say a solid 4 months of work to really understand and get in the mind of this vascular surgeon or IR interventional cardiologist, whoever that may be. It's certainly an investment. And the techs live in usually a dark room where it's quiet. We can take our time to adjust the machine. Certainly not in the cath lab. Time is of the essence. And when you're doing balloon inflation, I am fixing all the settings on my machine, because I know as soon as that balloon comes out, I'm putting the probe on, because I want to know if there's a dissection. So it's I suppose 4 months is fair. I'm always learning, though.
But what's funny is you said about the acceptance of the staff to a new member, to a new role of the ultrasonographer being there. What's funny is nowadays, if we don't have an ultrasonographer in the room, it's like a big stopping block. Are you sure? We can't start. They're not here. Kaylin's not here, or Abby's not here. So it's amazing to see the progression of the thought process between it's nice to have them, to like, we can't do this without the interventional ultrasonographer. So, and that's why I feel strongly that this field is going to grow, and you guys will be teaching a lot of your peers down the road of how to be in that role, which I think is very important.
Thank you.
Fadi,
well,
you're
I just
in a situation... Sorry, go ahead. You go ahead, Jill.
I just invited Abby to join me for a discussion at SVU annual meeting to talk about this role of interventional ultrasonography. So I'm so excited to do that with Abby.
Dr. Saab, you work at multiple different centers, and you want to try and figure out from your population of sonographers who's going to be good to transition into this interventional role and who's not going to be good. Can you kind of walk me through how you find the right people for this?
You're putting me. Why doesn't Jill take that one? No, I'm just kidding. This is gonna sound a little bit extreme or a bit cheesy, but it's really a scouting mission. So I'm always looking. I'm always looking for when we have candidates, because I would say, quite frankly, we've had people that I've invested time and effort in, and ultimately it did not work out for them to be in the lab, not because they're not good or they're not committed, but it's just you need a certain type of personality and passion behind it. Again, I'm not suggesting they're not passionate. It's just they're not. That's not their role. And to be honest with you, Jill said something very important. Usually the thought process and the training, and that's not a criticism. It's just the way they're trained. You're in a dark room. You usually have calm music on. You're dealing with a nervous patient. Everything is very like methodical, organized, and relaxed. And then suddenly you take all that and you turn it upside down. And they're supposed to be working under pressure. They're supposed to be, interacting with different personalities. If there's something going wrong, they need to be good under pressure. So all of those things are important. But to answer your question is, you want to look for someone who is willing to learn. And I say that as a generic answer, but really tell them that, okay, all of the knowledge and the foundation that you have as an ultrasonographer, now I need you to apply that in a different capacity, in a different way. And quite frankly, the book is not written yet. I'm hoping Jill and Abby and our interventional ultrasonographers will write this book and do this curriculum. And I'm not joking. This is going to be in the next 5 years. I think this is something that's going to be educated and trained to other ultrasonographers, because there is no book. And I always give the example, the doctor is telling the ultrasonographer, okay, show me the catheter. And the ultrasonographer will look at the physician and say, what do you mean? What's a catheter? Right? So that's always the example that I give, because the physician needs to understand that our ultrasonographers do not understand the interventional universe that you're in. So it takes a certain type of personality, intrigued, they're very engaged, they're scientific, they want to grow, and they're intrigued by this idea of being a member of a team, and they're willing to put themselves out there to because not every physician is going to be, warm and inviting, and some physicians, their idea of support might be putting you under more pressure. So I'm looking for those personality traits that will allow he or she be able to act under pressure, and they're willing to accept criticism, and they're willing to expand their horizon and their role beyond what they trained for at school. So it's I'm not gonna say that I'm always good at that, because I certainly failed in multiple cases. And Jill, you're very good. I would say we need good 6 to 9 months of training with interventional ultrasonographers to get them to the point where I feel that they are able to provide adequate feedback and add to the therapy plan with the physician.
I see, yeah.
Yeah, very reasonable.
And then, Jill, you've interacted with so many sonographers who maybe have been interested in doing what you're doing, or just curious about it. Can you tell me a little bit more about what you see as strong personality traits, or reasons? I guess what I'm trying to say is, can you look at somebody and say oh, this person's going to be awesome in the cath lab, or look at them and be like, I think they should stick to scanning people in the dark?
I mean, maybe sometimes you can tell. Yeah, I agree with all of Dr. Faab's points. I think where it becomes challenging for a lot of techs who've expressed interest that they want to be in the cath lab is actually, we've got a problem with reimbursement. We don't get paid to be in the cath lab. And it's really the physician investment. Like Dr. Saab, you've invested in your techs to stand there and be a part of the team, which is so valuable. And half the time in Dr. Constantino's lab, I am wearing lead, jumping in and out of the case because I got to go scan a patient to go, keep the lab rolling, because right now I'm the only tech. So she invests in me. I come in on my days off and I won't miss a case if I can help it because I want to be there. But she also is paying me, in a non-reimbursable, area to be part of the team. So I think that's an interesting thing to bring up, is how do we make forward movement for the ultrasonographer to be, reimbursed for the case? Any thoughts on that, Dr. Fadi?
And Jill, you bring a very good point, and we don't want to make this discussion, outpatient versus inpatient, but one of the biggest challenges that I know you hear that, I hear that all the time. Physicians coming and seeing what we do and really impressed by it and see the value in it. And by value, I don't mean the value in only success. I mean the value in safety for the patients. And that's something that trumps I think in all of us' opinion, that trumps anything else. The level of safety that's afforded and provided by incorporating extravascular ultrasound in the lab is unprecedented. Yes, we're talking about anecdotes, but in the next 5 years, I think the data is going to keep coming more and more and more about the safety provided by your presence in the lab. Having said that, a lot of physicians that work in hospitals or institutions and or employed by hospitals, the administration sometimes, not all of them, but the administration sometimes fails to see that, we're not getting reimbursed or paid for your time, your presence in the lab, and they cannot, in their mind, justify. Unfortunately, they're not looking beyond the okay, you're an ultrasonographer, you need to be reimbursed for your time spent in the lab. Versus people like Dr. Castino, ourselves, and other labs, Dr. Craig Walker's labs in Louisiana, they all have interventional ultrasonographers because they see the value in, if we avoid one complication or if we're successful in one more case that otherwise we would not be successful in, and that trumps everything else. But how can we bring this to the payer and convince them that this is important? I think that's ultimately going to end up requiring us showing data that shows that we're able to increase success rate and decrease complications, obviously translating to saving lives by doing this. So that's why we're in the early phases of this place. I wish I'm optimistic about being reimbursed for this, but I don't think this is going to happen anytime soon unless we show more data.
Is there a way for us to, there's only a handful of centers that are doing this, like almost joining forces. And I think, is that how we're going to make forward progress?
Completely agree. And it's almost yes, it's going to be retrospective or prospective, looking at centers that have interventional ultrasonography models, compare their complication rates. Quite frankly, let's just put it frankly, comparing complication rates in a center that has interventional ultrasonography in there versus centers that don't have interventional ultrasonography. Yes, the rate of complication, thankfully, thank God, is low, but you need, 500 patients or 1,000 patients in each group. And look, is there a difference when you apply those things? Because I have tons of examples. You have tons of examples of, I saw a complication, or I saw a hematoma. We caught it right away. We did something about it right away. But that's remains anecdote unless we show data. And I agree with you. That's maybe the birth of an idea that we should combine these centers that have interventional ultrasonographers and start collecting, the rate of complications in these centers that have interventional ultrasonographers.
Well, yeah, you mentioned your anecdotes. Fortunately, I got to see a really cool case where Jill found a dissection and, it was something that wasn't really visible on fluoro and then able to treat it. Could you share with the audience a couple other anecdotes of how EVUS has been helpful in your lab, maybe from recent cases?
For me? So let me paint you a picture. This is a realistic picture, and just goes to the heart of like, who would you choose as an interventional ultrasonographer in your lab? You're doing an intervention, and these are sick patient populations. They have frail vessels. They have calcified vessels that are prone to complications such as dissection, or in extreme cases, perforations. And with perforations, you start having bleeding. And if you have bleeding in the thigh area, that's different than having bleeding below the knee area where there's compartments. And it's much, I keep saying that ultrasound is much more sensitive than angiography in identifying perforations. So one of the examples is we were treating an anterior tibial artery, that's the anterior compartment below the knee, and we took an angiogram, and the angiography was not really clear, even though it's digital subtraction angiography. And I was concerned about the perforation, and our ultrasonographer, her name is Caitlin. She said, I would like to scan the anterior compartment. And before you know it, she's placing the probe on there. She changed her settings, and she said, Dr. Saab, I think there's a collection forming there. She was able to show me the bleed. And between the image to the point of starting the bleed, it was about 90 seconds. So we initiated our protocol for a perforation, balloon, external compression, the whole 9 yards. In 15 minutes, we were able to control the bleeding. We identified that it was a branch perforation that was managed by conservative therapy. But here's the challenging part. All of us in the room looking at the ultrasonographer who is scanning the anterior compartment of the patient. And I'm waiting as a physician. Now, I want to paint the mental image for you. I'm waiting as a physician. The staff is waiting as a physician. Do we still have continuous bleeding going on there or not? Because if we still have continuous bleeding going on, we need to do a certain things, including calling vascular surgery because maybe a compartment syndrome is being created, including placement of a covered stent, right? So there's a lot of pressure on this ultrasonographer to make an educated decision. And that's what I meant by you need to identify the person that's willing to accept that kind of ultimately it's a physician's decision, I understand, but I depend on them to help me interpret the images that I'm looking at. So that's one of the examples. Nope, the location looks fine. The compartment did not change in the size. They already measured it, minimum bone diameter of the area. You can proceed, right? Big difference versus I don't know what to do. I'm just going to send the patient to the hospital. They're in the hospital. They got an infection. Things got complicated. So the consequences of knowing versus not knowing is completely different. This is a patient that ended up going home and it's fine. Versus, nope, you have a major bleeding going on here. You're not able to control it. You need to do something different, and you need to do something different fast.
Yeah, that's a great example. Jill, do you have any recent cases you'd like to share?
Yeah, Dr. Saab, I so appreciate that story because it happens, and all eyes are on the ultrasonographer to make that decision based on what I'm seeing at this moment. And oftentimes, maybe not in an example like that, but we see a dissection on IVUS, and ultrasound's really sometimes the tiebreaker, and the patient's wiggling, and you have to be very quick in your decision making, and sometimes you have to pop around to many different places. I'm down at the foot, I'm down in the groin, we have to be quick on our feet, and going back to the ultrasonographer, we work in precarious positions, as you saw, Dr. Baheti. Like I'm navigating the C-arm, and we're sometimes it can be very tricky, intense, and I think we add so much value to that decision making when there's a problem, and I couldn't agree more, Dr. Saab.
Fantastic. Yeah, it's a really an amazing thing to see if you get a chance to visit one of these centers and see how they do it. Let's talk a little bit about a specific case scenario, CTO crossing. Can you guys walk me through how you use EVUS and IVUS in that scenario? Jill, let's start with you.
So Currently, I'm working with Dr. Constantino, and she does use IVUS. Previously, when I work with vascular surgeons, we used more EVUS than IVUS, and so it's been really nice to see both, in tandem, and the value that each brings. Oftentimes, though, we'll cross CTOs using ultrasound first, using EVUS, especially if the cap is amenable, and we can just park the wire and the catheter right at the CTO cap. And there's a method, and I'm sure Abby and Ben can agree to this, and you too, the tech should not move. And you get a lot of techs, we're used to moving this probe all up and down the leg, and when you have the CTO cap, you hold steady and you are constantly communicating with the physician because all eyes are on that duplex ultrasound. That's what we have. So we use it a lot. And then you also know when to step away, like nope, use fluoro. Like it's constantly this back and forth. And in really nice situations, it's nice to traverse the entire, CTO with EVUS. But we go back and forth, and then obviously confirm true lumen with IVUS. Dr. Saab, do you have any other examples?
Yeah, so in 2018, 2018 or 19, we published a paper called the CTOP paper in Journal of Endovascular Therapy. And at the time, we looked at, I believe, almost 150 CTOs. And at the time, we looked at the cap morphology, or the way the CTO cap morphology looks under angiography or even under ultrasound. And the point I want to make is, based on the CTO cap morphology, we've determined how we're going to tackle this CTO in an antegrade fashion, in a retrograde fashion. Do we need pedal access? Do we need column femoral artery access? But what was interesting about this trial, which we don't talk much about, is how much correlation was there between angiographic assessment of the CTO cap morphology and ultrasound assessment of the CTO cap morphology. And the C coefficient was about 0.8, which is really an excellent correlation in ultrasonography and angiography. And I mentioned that because a lot of physicians says, okay, well, I don't have a Jill in my lab. I don't have an Abby in my lab. And they feel it's all or nothing. Let's face it, when we started, we did not have an interventional ultrasonographer in our lab. Like everybody else, we tried ourselves. We brought ultrasonographers in. We bribed them with coffee and Starbucks card. And, we begged, and, we've had very intrigued and smart people like Jill that said, you know what, this is really cool. I'm going to come on my time off and do it. But at the end of the day, I said, but at least you can go to even the diagnostic lab and request that within your diagnostic evaluation of these patients, you can at least determine the cap morphology for the physician. And I know Jill does that without anybody asking her, because she's already thinking in her head, like, okay, this patient is going to go to the lab. They have a CTO in the superficial femoral artery. Let me show how the cap looks. Is it concave? Is it convex? Is it a pile of rock, calcium? Like she said, yeah, EVUS is not going to be helpful to visualize things through it, but guess what? This is a very valuable piece of information to the physician, that I'm dealing with complex anatomy and I need to change my mentality, and it's not going to be 5 minutes just in and out, right? So it really helps with the planning and organization, and quite frankly, not wasting your time attempting things that it's not going to work. One of the most frustrating things for me is when people say, well, I'm just going to try, and if I don't succeed in 10 minutes, then I'm going to switch. Well, right now we have evidence, we have data, we have prediction models that, you know what, when you see a certain type of anatomy, you need to do 1, 2, and 3. This concept of let's attempt and see what happens is, quite frankly, a futile and a dying methodology. This is what I hated most during training is let's see and try, and you never know. I hated that very, very much. Now we actually, because of ultrasonography, we have a way for us to create a plan, follow it, and my own educated experience based on what we've been doing for the last 10 years or so. You're you're more than 80% of the time you're correct in the way you plan things, based on the information that's afforded to you by ultrasonography. Jill?
Yeah, I mean, that case that you saw, Abby, it was a flush SFA occlusion and nice concave cap from the foot, and it was lovely, and I think the success is higher. It's easier on the patient, and as you've said before, it's the safety. I mean, gosh, we use, just like you, we use ultrasound for closure of the pedal access site. It's really, really lovely. So I think, well, I'm also curious, Dr. Saab, about when you cross, like, tell me about your algorithm of when you're introducing IVUS.
Right. So, Abby, if you remember, that's why I said, hey, let's change the title from EVUS versus IVUS to EVUS to IVUS, a continuous spectrum. And I really, that's how I think of it. I think of the two imaging modalities as complementary to each other. And I think of EVUS as a modality that's going to help me guide my catheters and wires, especially in chronic total occlusions. I think of EVUS as a modality that increases my safety in terms of obtaining access and in terms of securing that when I finish the case and use a closure device or even manual pressure, I'm confident that we're not leaving the patient in a situation that they can be bleeding and we don't even know about it. I'm using EVUS to look at possible complications that I'm worried about during the procedure. All of those things cannot be achieved by IVUS. I mean, let's highlight how they're different from each other. But fast forward to yes, you cross the lesion and you traverse this complicated anatomy, even if it was not a chronic total occlusion, even if it's just a patent vessel. Now, the role of IVUS is very important. I don't think it's as relevant for people like Jill and us in terms of sizing of a vessel, because EVUS was doing a pretty good job in terms of being able to size these vessels and understand them. But what IVUS was able to do is allow us to look at in a more granular way, the composition of the plaque that we're treating. The IVUS that we use in our labs is the Philips. There's two types of IVUSs. There's the Boston Scientific intravascular ultrasound, and there's the Philips ultrasound. The Boston Scientific ultrasound is a higher frequency, and it's a mechanical intravascular ultrasound system, 40 to 60 megahertz, and it has a mechanical component, meaning that it's rotational. And that comes with its own sets of challenges because you have a rotating component, not good or bad. It's just as an operator, you need to be mindful of these complications and artifacts that's related to it. And then you have a multi-phase array intravascular ultrasound, 20 to 40 megahertz, which is the Philips ultrasound system. There's other systems out there, but those are the two most common intravascular ultrasound systems. And the Philips system tends to be a little bit more user-friendly, even if you use some of their latest consoles, their touch screen, the LCD, there's a lot of tools that are literally at the table side where the physician can do all sort of analysis while they're there, and it takes less than 60 seconds to connect it and perform the analysis. So I think it's very important to be able to determine the plaque morphology when you're working on it. But something that we don't talk a lot about is how much disease is being missed by angiography that you're able to identify by intravascular ultrasound. That's something that it's not a lot of people are talking about. I think it's going to be very important. I think it needs to be big part of what we do for a lot of patients. So right now, everybody somehow, including myself, before IVUS, we tend to think like, okay, you have a lesion in the proximal SFA and then a lesion in the mid-popliteal and maybe a lesion in the distal tibials. But when you perform ultrasound, you see this systematic disease, this deadly disease, PAD and CLI, affecting the whole vasculature to varying degrees. And that really changes your way of thinking in terms of what you're going to treat. So by angiography, you would not this is my own assessment. I think angiography underestimates the true nature of the disease by anywhere from 50 to 70%. This is my own experience. It's not published data, but that's my own, because I compare myself to myself before we incorporated intravascular ultrasound in our practice, and you notice a big difference. What you saw in angiography that looks pretty normal, you do intravascular ultrasound and you're like, how I would have missed this. I wouldn't have been able to see.
So that's been a critique I've heard, from people about using IVUS for every case, is that IVUS will show you things that aren't there on your angiogram. And I guess my question is, how do you know that treating the lesions that you might see on IVUS that aren't maybe clinically significant on the angiogram, how do you know that the outcomes are going to be better?
Yeah, that's a great question. Thank you for asking that. But it's mind-boggling to me that when you challenge, and not challenge in a negative way, when you ask the person who's asking this question, do you think what you're seeing is not real? And the answer is no, it's real. Do you think that angiography is providing you with a better image than intravascular ultrasound, or intravascular ultrasound is providing you with a better image? They say no, intravascular ultrasound is providing us with a better image. So this analogy is putting the carriage before the horse. Everybody wants the data and wants the evidence behind doing something, but we cannot have data unless we collect it, unless we attempt a strategy. I will say, as a cardiologist, and then I hope this will be my only cardiology analogy, and I apologize, but we have tons of data. I would say, I'm not exaggerating when I say more than 100 trial looking at intravascular guided percutaneous coronary intervention versus non-IVUS guided interventions, and the difference is crystal clear. And believe it or not, we have data in the peripheral space that shows that outcomes, hard endpoints, hard clinical point outcomes in patients with critical limb ischemia. So I'm talking about amputation-free survival. I'm talking about treatment for patients. Patients who received intravascular ultrasound assessment with critical limb ischemia had better outcomes than patients who did not receive intravascular ultrasound during their evaluation of critical limb ischemia. And Dr. Sosomsky's work is phenomenal in that space. There's a lot of the data that's coming out looking exactly at that. So I think the camp that's arguing that, well, how do you know that this is beneficial? Yes, I agree that cannot be only logic and the opinions of people like myself. We need to have hard data. But right now, I think it's the onus is on them to prove why this technology is not working.
Very well put. Yeah. I've transitioned. I trained in a program that didn't use that much intravascular ultrasound, especially on the arterial side, and I've transitioned to using it for all my cases. And I just like you feel like I see things that I wouldn't have seen on the angio. So,
let me ask you this: would you even comprehend performing stenting in a May-Turner syndrome without the use of intravascular ultrasound? Really, theaters on the point of crying if you don't use it. Would you agree? You just, who would not use intravascular ultrasound right now for May-Turner?
I've taken the IVUS machine in my car to hospitals to do May-Turner cases because I know they don't have it there. That's how strongly I feel about it. So we're on the same page. Jill, how about you? What do you think about using IVUS for almost every case for the arterial side?
Yeah, I think I'm in an environment now where I see it used throughout all the cases, and it certainly makes sense. I feel like the ultrasound EVUS can be such a nice complement to IVUS, especially it drives Dr. Montero Baker crazy when, we talk about limiting dissections, and put the ultrasound probe up there and look and see if it's flow limiting. Do we have a waveform change, or is it non-flow limiting? I think there's a lot of valuable information that we can get from EVUS when we see a dissection on IVUS. So I think they're very complementary.
Well, awesome. Coming from like a more community-based practice, if I wanted to start doing EVUS in my lab, per se, and maybe I've identified a sonographer who I think would be a good fit, what are my next steps to get that person into my lab?
Jill, I'm gonna
Dr.
turn
Saab?
this one to you first. This is on you.
Well, I had the privilege of having Dr. Baheti's tech in our lab, and she seems excellent and very passionate and excited to be there. But we have to also recognize a lot of these techs have never even seen a wire or catheter. And I spent time with both of the techs that were there and said, feel it, look at it, imagine it. And so I think to go down that road, it's an investment of your time into your techs to bring them into cases, to talk through like what is in your mind. And, I'm just 300 miles south, so I'd love to have her come down again. But, it's that investment of time, and
just having him around for kind of everything you do, having him see cases, seeing if they're a good fit. Yeah, all that stuff.
Yeah, I mean, to be honest. Oh, sorry.
Go ahead, Jill. I'm sorry. Go ahead. No, go ahead.
I was just going to say, even if you're not going to have an interventional ultrasonographer in your cath lab, every vascular technologist should step foot in a cath lab, and they should see the case that they did the ultrasound on, because we have misses, and this is how we learn. Every tech should have the experience of seeing a case that they scanned and putting all of these pieces together, and that probably also goes for endarterectomy versus TCAR, open bypasses versus endo. I mean, we have to have this higher level of thinking in all of these vascular beds to do better in the outpatient or inpatient, regular ultrasound scanning. And that helps with reporting and patient outcomes, I believe.
One thing I would like to mention in bringing an ultrasonographer into your lab, the physician that's doing this have to really accept responsibility for that person. And what do I mean by that? They have to accept that they are mentoring that ultrasonographer. And that includes empowering them to be verbal. So if you're only, as a physician or as a team, you're only as strong as your weakest link. And I don't want to make it like a speech, but to be honest with you, unless you as a physician empower that that person that's coming to an environment that's completely different than the original environment, and basically putting the onus on them to be an important member of this team and affecting the livelihood of a team, and most importantly, affecting the livelihood of a patient. Because if they make a mistake, or there's an issue or something, or things don't end up being the right way, that is a lot of emotional toll on those people. And the physician needs to be in a mentorship position, empowering those individuals to be like, you're not in this alone. Yes, this is a new field, but I trust you. I am with you. We're going to do this together. And if a mistake happens, and mistakes do happen, unintentional, obviously, they'll feel terrible. They'll feel bad. They'll say, I'm not going to step a foot in the lab again. But you know what? That's a sign of a good person. That's a sign of a person that you want to be a member of your team. Because if they didn't care at the end of the day, you don't want them to be in that team. We all, as physicians, we all have good days and bad days. And that's just the way it is. Jill, the same thing. We all have good days and bad days. You want to go home every day with 100% success, but the reality is we don't have that every day. And, we can't change that. That's part of who we are as healthcare providers. But unless the physician does not accept the responsibility as a mentor for this individual that they're bringing into a team, they're not going to be successful. You have to do your part in empowering these individuals.
Well put. Yeah. Well, we're kind of wrapping up on our hour here. We talked a little bit about different devices for IVUS. Jill, would you like to speak quickly about different options you have for EVUS?
Yeah, I was just thinking, to empower your techs to be in the, or to bring them into the cath lab suite, we've got to have updated ultrasound systems. A lot of cath labs, some just have a SymphonySuite that we use for access. And I know Dr. Saab and, Dr. Constantino and Dr. Montero Baker, we have high-end, whether it be Philips or Siemens or whatever system it is, but we have to have good ultrasound to do these high-end procedures. And so arm them with the proper equipment and probes that they need for success.
Yeah. In most cases, just having at least one linear probe will get you most of what you can see, right? Any tips and tricks on what to look for when you're investing in a high-end system?
Yeah, I think a linear probe and certainly a high frequency. We use a hockey stick probe for pedal access.
Okay, perfect. Is there anything else that you'd like the audience to know about how you use EVUS and IVUS in your lab every day to take care of patients?
Well, I'll tell you one thing that maybe throw in a pearl in there. We have 3 centers between Michigan and actually Las Vegas. Don't ask me why Las Vegas, but we have a center in Las Vegas. So, in one of the things that we initiated actually last year was an ultrasound guided access protocol. And for people that hear about it, is like, yeah, everybody uses ultrasound for access, or they think they do. But we actually made it a policy that we shared in all of our centers. And what the ultrasonographers are expected to do is, regardless of the access, mostly the common femoral artery, antegrade or retrograde, we actually will document the vessel size, pulsatility. We will document compressibility of the vessel. All of those images are actually part of the intervention. And after we obtain access with the needle and wire, we actually will document the compressibility of the vessel with the needle and the wire through it. And that image gets saved into the system. And what we're trying to show here is A, the access point within the vessel. So if you have a hematoma, you're not guessing anymore. And B, that we're actually able to compress this vessel at the end of a procedure, even if you're not using a closure device. And then at the end of the procedure, if you use a closure device, regardless of a closure device, we actually use ultrasound to guide closure, like Jill said. So, PerClose or AngioSeal, those are intravascular devices. Even the Minx device, it's an extravascular device. But after we close the arteriotomy site within the common femoral artery, then the ultrasonographer, the interventional ultrasonographer, will document hemostasis under ultrasound. And again, that's part of the system. So we know that the patient is leaving the angio suite with hemostasis. That's for the common femoral artery. For pedal access, we just published our case series, about 500 patients with pedal access. We found that the rate of closure of tibial vessels related to ultrasound-guided access at 30 days is about 6.9%. Since that, we've initiated ultrasound-guided closure of pedal access, meaning using a high-frequency probe like the hockey stick probe, we will apply pressure to the access point and allow patent hemostasis. And I can't do it. So only people like Jill and Abby and Kaylin, they can do it. They can modulate the pressure at the access site and allow patent hemostasis for 3 to 5 minutes usually. And that's for us. We don't want to see closures within the access site related to our access. So the point I'm trying to make here, that we have protocols solely revolving around ultrasound-guided access. The point is, the goal is always to decrease the rate of complications in these patients. And it doesn't impact your workflow. All of us are willing to invest 10, 15 minutes extra if it translates to better safety for the patient. And I think this is going to be the future in a lot of the centers around the country.
Fantastic.
I love it, Dr. Saab. I love it so much because I think there's just so much value in extravascular ultrasound and ultrasound in the cath lab suites. We just have to find a way to collaborate and bring it. It should be a higher standard, and bringing ultrasound as a standard of care for patient safety in the cath lab. So I could listen to you all day. I think we're all doing, very similar work, and it's outstanding.
May I propose actually, and this is just an idea for the BackTable team. I would love to listen to Jill, Abby, Kaylin. Abby and Kaylin are ultrasonographers with us here, and actually have an hour just talking to them about what did it take for them to move from being an ultrasonographer to an interventional ultrasonographer. Honestly, I think a lot of physicians will love that, but I think ultrasonographers will love that. And it'll be I'm just throwing an idea out there. I would love for you guys to have an hour doing that.
I think we can make that happen,
I think it'd
right?
be fantastic. Yeah. Yep.
Well, I mean, seriously,
awesome.
Don't you think so? Like, so many physicians, like, how did you do it? How did you do it? How can I train my ultrasonographer? How many times do you have ultrasonographers coming to you? I'm like, okay, my doctor is mad at me. Tell me what to do. I don't know how to do it. I mean, people want to know. There is so much hunger to that. And who's better than you guys to talk about these nuances? I mean, Jill, you said something like, nonchalant 5 minutes ago, but you know how long does it take me to teach ultrasonographers to do that? She said, as an ultrasonographer, you got to learn not to jump up and down. She said it like in passing. That's a critical point. Number one, for the physician to tell the ultrasonographers, stop the rocking motion, because that's how they're trained. The ultrasonographers, that's how they're trained. They have to have a rocking motion. That's the proper way of doing it. And then it took me 6 months when we first started doing this to say, why are you moving back and forth? And they're like, what do you mean? That's the way we're trained, right? So it's pearls like this that only these guys know how to relate to others. I would love to hear like a talk like this, just teaching ultrasonographers how to do it.
All right. Yeah.
I think
put
that would
it
be
on
fantastic.
the docket. I think we can make that happen. Jill and Fadi, thank you so much for being on the program today. I really appreciate it.
Thank you, Dr. Baheti, and thank you, Dr. Saab.
Thank you, ladies. It was a pleasure being on, and I really appreciate the opportunity to participate with such great company. So
good way to spend
you.
your Saturday.
That's right.
Did that kind of
Thank
cover
you.
everything you guys wanted to talk about?